Welcome to another AI Live.
And we're so festive here. We're so festive. And it smells like pumpkin spice. So you guys can't smell it, but we're totally into the Thanksgiving feel.
More eating.
I know.
More eating.
Turkey and dressing. Love it. Yeah, we love it. Thanks for joining us, everybody. Thank you. We have a good show for tonight.
Yeah.
We have a really informative show.
Hopefully you guys will get a little interactive. We'll try and answer some questions. We have a little PowerPoint, but before that, what have you been up to this last month or this last weekend?
Oh, this last weekend. Last weekend I was in Atlanta. I flew out and went to a Dermal advisory board meeting on the new re-release of Sculptra. So there's a lot of new stuff coming out. Super excited about it. And the education platforms that are coming out, and we've used it for years. We love it. So super excited about this. So I was in Atlanta this weekend, and I'll be in Delaware next weekend with my wonderful friend Emily Rockwell, who I went out and trained about 4 years ago, and she's a brand new nurse practitioner. And again, I've been out since then, but I'm going to go out again and train her, and she's become the Julie Horn of the United States. She's the lip queen. So I get my lips done. I'm so excited. So Emily's gonna do my lips. So anyway, I'm so excited to go out to Delaware next weekend. But
awesome.
So what's up with you? What did you do last weekend? You had your birthday yesterday. Happy birthday.
I just got old.
No, you didn't. You'll never be old.
No, I was in Napa. I got finally a weekend off, and we went to Napa. We drank a lot.
It's your birthday.
And I ate a lot. Well, as you can see, my face is probably huge, but it was fun. It was fun. But now we're back to work. I think this weekend I'm training for Mint, a whole full Saturday, 12 hours of training. So we'll have fun training some threads.
Those are fun. Threads are fun trainings.
Threads are amazingly fun to see the results and everything. I love it.
There's fun. We always have fun, you guys. We do get days off once in a while, I think.
Somewhat. Somewhat. But we have fun doing this.
You went to
Napa. Right. So now on to tonight's topic. I know a lot of you guys are interested in this topic. And so we're going to be talking about dermal fillers, kind of side effects, managing them. I think, there needs to be a delineation from what really is a true adverse type of complication to what is potentially an injector fault, and how to kind of recognize it and understand, what to do in those cases. I think we don't take sometimes we as practitioners don't take enough responsibility for some of the mistakes that we make. And you have to realize you have to make some mistakes. You have to understand why you made the mistakes and how you're going to correct it to improve. And so you have to admit that you made a mistake. And yes, it sucks to have to admit, oh, yeah, I probably injected in the incorrect plane, maybe injected maybe in the muscle. But really, those are the times where I think you learn the most, when you challenge yourself to figure out why did that happen. And those are the times you work with your community. If you have a community, try and figure out why did that complication happen? What's going on? How do I manage the complication? But the goal, hopefully tonight, is to kind of go over some of the more common things that happen with dermal fillers and the injectable complications that happen.
Yeah, more than just vascular occlusions.
Yes.
Because everybody talks about vascular occlusions, and sometimes that might not happen very often.
They probably don't happen as often as the nodule formations and swellings and all of that type of stuff. So I honestly think that this should be more of a talk than all of the vascular occlusion conference things that are out there. Ultimately, you have to understand the whole gambit of it all, and then take it in small excerpts that things do happen, and understand when they do happen, how to manage it.
Right.
I think vascular occlusions is the one that we go to the extreme. It's kind of like driving a car, like you're going to get into a big accident and kill someone. Well, you know what? You may get a little fender bender here and there. Learn why you got a fender bender. Stop texting.
Don't do it. Just don't do it again. Learn, and that's huge because I've seen some injectors who have had quite a few occlusions in the same area. And I think, okay, think about what you're doing and step back and either go a different depth, a different location, aspirate for longer, whatever it takes. But I mean, think about why that happened so it won't happen again. I think that's really important. But we're not going to talk about occlusions all night long.
No.
Promise, we are not. So we want to, here, we're going to kind of show you a little bit here, but we want to
jump into our PowerPoint.
Jump into our PowerPoint.
So little disclaimer.
There we go.
Okay, you can see the little disclaimer. It's for educational purposes of what we're doing this for. You don't need to know about me.
Look at your blonde hair.
I know. I kind of miss it, but oh well. Too much maintenance.
Oh gosh. That's me. You guys hopefully you kind of know. It's Okay, so types of filler complications. We have quite a few different types of complications. You can have a venous occlusion, you can have an arterial occlusion, or a non-inflammatory nodule secondary to your technique. So basically you put a lump there. So all of those are going to be pretty immediate within the first few hours. Late onset can be a hypersensitivity reaction. So people could be allergic to the products that make the fillers and of the fillers. You can have an infection, which may lead to a biofilm, and you can have inflammation that leads to nodules, or you can have nodules from a non-inflammatory base too.
Yes. And so you really, I mean, as far as like time frames with regards to these immediate, to me with these two, of course, vascular occlusions, probably the fastest for the most part, unless it's an allergic reaction. You're probably going to see this within 12 hours. Some are going to be immediate, but rarities to me that I think you see completely immediate unless you put a crap load of filler in there. I think the two that I've had, one on the nose and one in the nasolabial folds, were 12-hour later type of evolution. So I don't think you could say that it's immediate, but probably we're categorizing like non-inflammatory secondary to technique. I think that kind of elucidates itself probably from immediate to even 3 to 4 weeks out. I think are what I would consider kind of in the intermediate. I think late onset to me would be anything about probably greater than 4 weeks.
Yes.
So your biofilms, like this underlying type of infection, the inflammatory nodules that pop up are probably going to be like, they look great, and then all of a sudden they're starting to get the little bump or and it's getting bigger and things like that. So ultimately, categorizing kind of when these things would happen is important because it helps you delineate kind of where along this pathway, kind of your flow of algorithm, what could potentially be the cause of these complications.
So a couple things that you could do to reduce the risk, and we kind of know this through research, is to inject small aliquots. So try to inject less than 0.1 ml of filler with each site.
And to me, when we see this, and I see this all the time when you see a vascular occlusion talks, ultimately one of the things that I would probably say is smaller aliquots, smaller microboluses are probably more for me along the lines when I'm injecting more in that subcutaneous, when I'm kind of more fanning and doing things. I think when I'm on bone, on periosteum, I feel as though I'm okay in an area and literally putting 0.3, 0.4, 0.5. I mean, we do it all the time in the piriform. So I think you have to take this and really understand your anatomy as it relates to this. I don't know what your opinion is.
I agree. I guess sometimes we'll go down onto the periosteum and inject more than 0.1.
Yeah,
because the patient needs more than 0.1.
Sense. You go and put in 0.05 on the bone, you're not going to see anything. So then you keep poking this patient 0.05, 0.05, 0.05.
And it ends up being 0.2 anyway. I get it. I think the majority, when they looked at this with the study, they realized that people that were injected with more than 0.1, that people were just injecting quickly and holding the needle still had a more of a risk of a vascular occlusion just in the study. So they recommended less than 0.1, keep the needle moving and inject very slowly. So as long as we aspirate, I think I go in with an unprimed needle, and you can aspirate very, very quickly, and it tells you if you're intervessel or not. Not 100% all the time, but it sure is worth trying. There's no reason not to aspirate. And the other thing is, if you keep that needle moving, if you are injecting, if you keep the needle moving, then you might not be able to put much into a vessel and not enough to occlude anything.
Right.
So not being very forceful, not keeping that injection pressure lower than the intra-arterial pressure is the key. So even if you are in a vessel or like near one, if you keep that, if you're injecting very slowly and you keep the pressure coming out of your needle very, very low, not to exceed that intra-arterial pressure, you're not going to be able to send something retrograde. Right. Because the forward motion of that artery is not going to let it go retrograde, if that makes sense. So injecting slowly, I think, is really a key here with cannulas or needles.
Yeah, and I think it's understanding your injection tool and getting that extra, you could say, sixth sense, as we always talk about. When you're injecting, if you feel as though you're in a boggier area that feels like a blood vessel, I think nurses probably have much more experience of this, because you guys are finding IVs all day long. You literally pop and you can feel that you're in it. I think the physicians are probably at a little bit more of a disadvantage, because we do central lines and stuff like that, but we're not doing those all day long.
Yeah.
You don't get that extra feel. And so you can kind of feel like, if you're close to a blood vessel, redirect yourself, find where it really does feel. And I like your thing, it's drywall, find the bone. If you're on the bone, you're most likely not going to be in a blood vessel.
I always say inject thoughtfully and inject gently and respect the tissue. So if you go in there with a needle, don't just stuff it into the bone. You get through the skin, and it should be like butter until you hit drywall.
Right.
So if you tap on drywall, you're not hitting a vessel. So be very, very gentle and be thoughtful. Know your anatomy when you inject.
Right. And then, of course, cannulas. If you can use cannulas, definitely potentially safer.
Yeah.
Definitely HA fillers.
Dissolvable.
These are things that you guys can decide as you get more comfortable with what you're doing. Right. I think definitely these are guidelines. This is not the end all. I like to use needles. I use mostly needles. There's certain areas where I like to use a cannula because I think there's a benefit to using a cannula in the area. But for me, I love needles, but I use longer needles. So I take in like what Codafana talks about, which is coming in at more of an angle. When you come in at an angle, I'm actually going to be a little bit more safer than going straight down perpendicularly. So I actually don't do very much perpendicular injections in my personal injection technique. So take everything that when you're learning out there, take everything with a grain of salt and think critically, ask questions. Challenge the reason why sometimes people do it, because there's not one way to do these things. I think that's the whole goal of why Lori and I like doing this, is because she does it her way, I do it my way, and we get great results either way. Yeah. And so it's to teach you guys that you can do it however many ways. You just think critically on what could potentially happen, how to avoid it, and how you're using your tools to the best advantage that you have. Okay, so knowing your anatomy, right?
That's so important. Come to the cadaver course.
Come to the cadaver course. But knowing your anatomy, knowing where you are, supraorbital, supratrochlear arteries that are coming, from the brow, superior orbital area. Those are the areas that could potentially blindness. And, the rest of these blood vessels that you see, angular, facial artery, superior labial, infraorbital, you just have to be careful that you're going to get a vascular occlusion, and you know how to manage it. Hopefully you know where they are, so you don't need to manage it, so that you don't need to actually break out your Highland X's.
Yeah.
The whole goal is that
25 boxes.
How many vascular occlusions have you had in your, was it 14 years of injecting?
Oh God, let me count. None.
Exactly.
I have had none.
So, and I've had two. One I did on the tip of the nose, my most recent one. And then the other one was one in the nasolabial fold, but that was like a 0.1. That was just being kind of like irritated, about to dump the syringe away, and patient goes, "Don't waste it." Inject it. Oops.
It's always the last. Let me just do a little bit
Murphy's
more.
Law. Yeah. Murphy's Law. But ultimately, I mean, having done this for 17 years, and I used to inject noses with Radiesse.
Yeah.
So, I mean, I come from the old school mentality that vascular occlusions really don't happen as much. I think you're seeing much more because people aren't being careful about where they're injecting. We used to always just go to the bone, stay on the bone. Yeah. I think people are just a little bit more forthright. I don't know what's going on in the industry. They're not paying attention to it. Who knows? We'll have to do a study and figure out what's going on and why people are getting so many vascular occlusions. But I mean, I don't seem to do, even though I aspirate, I don't seem to get that many aspirations back. And maybe
you're using your needle
at an angle.
You are. That's what I was just going to say is when you take a needle and you lay it on the bone and come in at a low degree,
moving when I'm pulling.
You're in one plane.
Yeah.
You're in one plane, so you're not going through a lot of the SMAs and layers of tissue. So that might have something to do with it too. And I think a lot of it
when you're perpendicular and you're pulling and aspirating, people aren't stabilizing themselves and really doing that. So their needle, as they're pulling back, you're watching their actual needle bob up and down.
Yep, and
I think a lot of people
bets are off.
A lot of people get aspirations because they literally are pulling it through the blood vessel instead of staying on the bone. Yeah. So, things to think about critically as you are doing. These are the things that you need to think about as you're doing your injection. So, this is arterial occlusion.
Yeah, this is a big one. This is a big inferior labial occlusion. So this is one that I don't know. This one is one I saw from an aesthetic company, but it usually people might have pain, but keep in mind, pain is not something they might have. Why not? Our fillers have lidocaine in them, so they might not have any pain for a couple hours at least.
For sure.
And you might have injected a certain area like the lips, and the entire lower chin area could become pale and blanched and mottled. So you've got to look at the whole thing. And something like this probably came up fairly soon, but a lot of occlusions don't, like you said, don't show up for probably 6 or 12 hours. I don't let anybody fly in where I inject them and they don't stay for at least 24 to 48 hours. I won't inject anybody who flies out on the same day for this reason, because they don't show up maybe for hours later.
Yeah.
Yeah.
All right. And question to ask patients, this is stuff to, when they call back to your office, have something, that your front office staff who are going through all of this, I guess you could say telephone screening for you, you have to have something to make sure that you're not having them just, oh yeah, it's a bruise, don't worry about it, and then pass them off. You need to have something where they do ask a little bit more of questions. Do they have pain? Rate it on a scale. And it's typically pain that's different from the other side, because if you did both sides, one side, the side that's occluded, will typically be a lot more ischemic, so you have a lot more pain on that side. Noticing skin changes, especially that mottled lavender lace pattern, is important. And then, as we said, different from the last injection or different from the opposite side is important. Visual changes, I probably say that would be more if you're going to get a blindness case. That's going to happen. Typically, if it's a blindness case, that's probably going to happen much sooner, and probably when they're actually in your office in the area. And then, of course, have the patient send a photo, whether it's to a text message or whether to your email or something like that. Have someone that is understanding what a vascular occlusion looks like be able to take a look and see what's going on.
Very important. Very important. I hand out a paper to all my patients, this little card that has all of the information on it and my cell phone number. So all my patients I inject get my cell phone number in case there's a problem. I want them to call me, because they are my eyes and ears for the next 2 days.
Yep.
Yeah. So this is in Asia, noses are extremely popular.
That's why I was injecting Radiesse.
Yeah, there's a lot of nasal augmentation with fillers, or the non-surgical nose jobs in Asia, and some of them are dissolvable, some of them are not. But this is a patient who had a lot of necrosis and ended up having to have a skin flap put on her nose, and so
it can get progression.
See the progression where it gets red and you'll see about 3 days it starts to get vesicles on it, which can be confused as herpetic vesicles. So if somebody says, oh no, that's just an infection, a skin infection, or it's impetigo, or it's just herpetic, don't blow it off. Don't blow that off. If it's about 3 days after a filler, it could very well be an occlusion if it's hyperemic and it has some vesicles.
Yeah, and just, the tip of the nose is very, 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 very vascular. Tons of capillaries. I think injecting noses, in my book, injecting bridges to me are safer than injecting tips. Tips are always the area that I think I pucker a little bit more so, especially everyone's like, I want the tip raised up high. I want you to build it. Tip. Now I think now we have threads nowadays. I'm like, so much easier to do something in this aspect of it without running into these potential complications. But then again, there are noses that you just need to inject if you really are amendable to injecting a nose that you can do, but be careful. These are pictures, as you can see, glabellar necrosis, a nasolabial fold necrosis, as you can see. These are not something that you want to see at this point where you see the black and you see it really, really necrose out. So ultimately just be aware and make your patients aware of it. I know Lori doesn't let her patients leave if they're flying from out of town for at least 24, 48 hours, just in case they need to do something to dissolve it out, just in case a vascular occlusion arises. And these are smart little things. Think proactively for your patients.
Yeah. This actually is a colleague of mine. She was injected with CAHA, or calcium hydroxylapatite, in her mid-face. And if you look at the progression on the left side of her face, you'll see day 3, day 6, day 7. She started to get the vesicles at day 3, day 6, a lot of vesicles, a little bit of necroses. And it's non-dissolvable. So there was nothing they could do about this. And I'm just saying we need to recognize this early. Unfortunately, this was something that couldn't be dissolved. But if we're using a hyaluronic acid filler and can dissolve it, we'd jump on this immediately and try to get this dissolved, get this patient into hyperbaric therapy. There is something new out that I want to tell you guys about that is called EO2, and it is a transcutaneous oxygen unit. It is a pad that you can put on the skin or on the face, and I implore you, if you have a possible occlusion, you call this company called EO2. You have them delivered to the house usually with the same day they get delivered to the house. They keep that on there and it saves that superficial tissue tremendously. It's a new tool we can use. We're just seeing the benefits of it now. So between hyperbaric, hyaluronic acid, if it's something like this that's a CAHA or a calcium hydroxylapatite, you can't dissolve it. So you got to get into hyperbaric. You throw Hylenex in there. You do everything you can. But I just had a friend back east that had someone have this in their nose, and they threw the EO2 on it, and the nose I thought was going to be lost, and there was no sloughing. Nice. So huge difference with that.
Get the oxygen back into the area. That's what's missing.
Yeah.
Oops. Let's go forward.
This is a sad case. This is somebody who had PMMA, which is Biofilm or Artifil years ago. It is powdered plastic, kind of a plastic type material.
Polymethylmethacrylate.
Yeah. And this patient was injected in the glabella and within 12 hours was completely blind in their right eye. And that's non-reversible. Yeah. That's most blindness cases are non-reversible or irreversible.
Yeah, it is very, very sad. You just have to be much more careful if you do inject this area. There are people who will still inject this area. And, if you take a cadaver course, to me, how I was injecting this area before we knew all about anatomy and all of this stuff, I was like, you know what? I was actually injecting it pretty darn safely in a sense for having injected into the area. Having Codafana dissect out the area for me. So it's not that you can't inject these areas. You have to be confident in wanting to inject this area, knowing that these are possible complications, and discuss this with your patient that this is possible. There are people who will inject it and there are people who won't inject it because they decide not to for their own practices. They will rather sleep at night. Hi. Other ones of us are a little bit more cowboyish and are like, yeah, let's do it.
I think if you do choose to do more dangerous areas as far as blindness, which would be the nose and the glabella, make sure you have a crash cart, a vision crash cart. I have a tray that is just for vision, and everything's in there to treat a visual issue. And basically, I have retrobulbar cannulas. I'm not going to use them. I have a oculoplastic surgeon that is my buddy. That's within 45 minutes, half an hour of me. if I drive fast, which I like to, it could be 20 minutes, and I'm going to take that kit with all my Hylenex and go down to his office, and he's going to do that injection. Right. So be ready. Have that with you. Have your pen light, whatever, all your near vision cards. Have that with you, and have your vascular kit and your vision kit. I would say in your office ready.
Right.
Yeah. Speaking of kits, anyway.
Crash kits. You guys should all know this. If you don't, I'm sure we had other AI lives on it. We do. We have them up on YouTube. You can kind of review it. If not, reach out to Lori.
No, DM Dr. Walk. I was going to say, on the Hylenex, you guys, it says 10 to 16 vials. I highly recommend at least 20 to 24 vials. Have more than 10 to 16, because if you've got a small occlusion, it's going to be one full box, which is 4 vials, about every 15 minutes. So I need you to do the math and figure out how many vials you need. So I think 20 to 24 is probably a cheap insurance policy.
Yeah.
So infections, this is really rare.
Yes.
Really rare.
Very, very, very rare. Knock on wood, thinking back, 17 years, probably over thousands, tens of thousands of syringes. I don't think I've ever had an infection.
I had one.
Yeah, I don't think I've ever had an infection.
I had one. Yeah, I've had one that turned into a little abscess and ended up being, I used a cannula and I used tons of hypochlorous acid, but it was 2 weeks later that she got like a little abscess, and I used to let people put makeup on or whatever 24 hours later. Now I don't. See, you know how you look back and go, okay, what caused it? What could have happened? Mm-hmm. I think she put sunblock on the next morning, 24 hours later, and I think she probably inoculated herself with some staph. I think she probably inoculated herself with something from the skin. So that's what I'm thinking. So couldn't figure out anything else.
Was it at the site or was it at a distal site?
It was right at the site.
Oh, right.
Yeah, it was pretty close to the site. So interesting. So, so now if I'm using a cannula, I don't let anybody put anything but soap and water on for 48 hours. I let that hole heal up a little bit more.
Cannulas, definitely so. I think with your needle, you're probably
24 hours is fine.
A lot quicker because it collapses very quickly.
Yeah.
But you're looking for erythema, warmthness, tenderness. These are the things that you want to watch out for, as you would for any cellulitis or any abscess that's forming. So make sure you are able to recognize that. And then if you do, put them on the appropriate antibiotics, Doxy, Mino, Cipro. You start off with maybe Keflex if it's not too bad, if you're catching it earlier on. But
something
just make
that'll treat a staph or
exactly. Steroids, possibly, if they're really inflamed, you can put them on some prednisone, put them on a Medro dose pack. I think those are appropriate type of things to minimize that immune response into the area so they don't swell so much. But infections, they're rare. They're rare. I mean, I don't think that it really happens as often as we will talk about, but it's something to keep in the back of your mind as something that could potentially happen.
Now, non-inflammatory nodules are generally seen right after injection. So basically, this is technique driven. Yes. And the product is either too superficial, there's too much put in one place. The product might be too high of a G prime for the plane that it was put in, so it leaves a nodule.
Inject into muscle.
Yep, inject to a muscle. So it's just a lump. It's just a lump of filler.
Yeah,
and so, it's a lump of filler.
And to me, this is important. I don't think we stress it enough. We see probably a lot more non-inflammatory nodules than we think.
Right. Yeah.
I mean, I think your patients do say, "Oh, I feel a little lump here," and then we're like, "It's fine. It's not. You can't see it and stuff like that." But it probably is definitely secondary to your technique. Injecting it, definitely a thicker G prime product, too superficial, or secondary to your technique, and you're injecting into the muscle. It definitely happens, And I think we don't spend enough time in my books training people how to inject with finesse.
Yeah.
I think people pick up a needle and just like inject, and try and squeeze, and they really don't understand. It's like an artist. It's like having the brush stroke and really, really being able to make a thicker brush stroke and a thinner brush stroke when you need it. I don't think people pay attention enough to it, whether you're using a cannula or a needle. If you want more product, hold it there, push a little bit more product. If you want to thin it out, move either really quickly as you're pushing or push a lot lighter on your syringe. I think the finesse of using your tools is not something that people pay attention to or care to pay attention to.
Yeah, and the other thing is I find that a lot of people are not as aware of anatomy as they should be. And I think it's so important to visualize where your needle is and where the tip of your cannula is anatomically, so that you can be very thoughtful when you inject, and you're visualizing, because we're injecting blindly.
Yep.
So you have to visualize what you've seen in cadavers and books, and what am I bumping into? What am I hitting? What am I doing here? What plane is it? So it's very important to be thoughtful, to inject with finesse. Take your time.
Plan it out.
Have a plan.
I think people don't plan out. They just see,
don't.
oh, I see a little hole here, I'm just going to inject. I'm like, well, hold back. You know, if you're using a cannula, figure out how to get there, but maybe to inject the whole area. If you're using a needle, and I use longer needles, I'm not injecting straight into the area. I'm picking a point, maybe that I can reach that area, which I can reach other points. So I'm not poking the patient so much, and I'm really doing a nice soft finessing on that aspect of it. So I can't stress enough when it comes to these non-inflammatory nodules, the finesse of using your tools much more appropriately.
Yeah, I agree.
Inflammatory responses.
Yeah, some people are very hypersensitive to the products that we inject. It's really rare. I've seen it once in 14 years where somebody really had a reaction to a hyaluronic acid filler, and they can get swollen. They can get, it looks like a huge infection. There's the ones that need to be dissolved and need prednisone, and you can throw on antibiotics if you need to, but some people can be very allergic to the growth media that some of these hyaluronic acid fillers are cultured in.
Yeah, for sure. And you're going to treat it just like a normal kind of allergic reaction, try and get rid of the inciting factor, and then treat the allergy in that aspect of it. So if not treated, these can definitely lead into late onset nodules that may be a lot more difficult to manage. So make sure that, you let your patients know that if things are not how they should be, you've gone over the normalcy, especially ones that have done fillers before, is not normal, come back in so that I can take a look. I know some of our patients get a little bit more wary, like, oh, I didn't want to bother you with this tiny little thing. But, let them know that it's okay to reach out with you. Especially with social media, most of us, I tell them, if you have really any issues at any point in time, DM me through my Instagram so that at least send me a picture so I can see what's going on, and send videos. I mean, we're in this day and age, this social media aspect of it, there's very little reason why you can't get information and communication between you and your patients.
We did mention on that slide, know your rheology.
Oh, yes.
And it's really important to know your rheology. There are some products that have a tendency to have a little bit more of an inflammatory response, and a late onset nodule. It's just known with some of the products, which are a little bit differently cross-linked. So you need to know if your products are highly cross-linked, if they're high and low molecular weight cross-linking. Do they have a tendency to have an inflammatory response? And if they do, then how to manage that. So know your rheology. We're not going to call out any products here, but know your rheology and know the history of these, and then pick your patient very carefully and who to put them into, and inject into a plane that is not a muscular plane. More on bone and more on just subdermal area, and you have less of reactivity sometimes.
All right.
There we go.
So,
what did I just say?
Pick
your patient carefully. Yeah.
Patient is very important. And, dental visits are things that we don't pay attention to a little bit, but it definitely does. I haven't seen necessarily anything with regards to fillers, but definitely with threads, I have definitely seen it cause an infection on a thread when the patient did do it like a week after getting dental work. After getting the threads, a week later, they did go get dental work, and they ended up with an infected thread. And we had to put them on antibiotics. Luckily, that took care of it. But, that could have potentially led to us trying to dig that thread out and do a lot more invasive type of things. So just be a little wary for your patients that, any dental work does throw out bacteria into the facial bloodstream. And so you want to just watch out for that. Autoimmune issues, as we talked about, any allergies, inflammation can definitely be one of those things. You just want to make sure that, if they have a little bit more of an autoimmune or inflammatory response in their own medical history that you may not use certain fillers just because there's a higher incidence of nodularities, of inflammatory responses in those patients. So you just want to be a little bit careful when you're taking your medical history on that aspect. All right.
So delayed onset nodules are something that are tough to deal with, and it's something you are going to see after 1 month.
Yep.
You're not going to see delayed onset nodules before a month. It's going to be a regular lump of filler, or it's going to be a little inflammation. But we have delayed onset nodules, both inflammatory precursed from inflammation or non-inflammatory delayed onset nodules. So about a 0.5% incidence, but we have to keep in mind the majority of adverse events are not reported. So majority of, how many of people have reported their vascular occlusions who have had 10? They're not reported. So about 40% of the delayed onset nodules had identifiable immunologic trigger. So watch out for people who have autoimmune issues, because when we use certain products that have different types of molecular weights in their cross-linking and in their rheology, low molecular weight. Okay, I'll say it.
It's true. I mean, when you compare it
has a little bit higher risk to having inflammation leading to a delayed onset nodule.
Yeah, for sure.
Yeah.
And these was, as Lori said, these are going to happen 4 weeks out. It's going to be a lump, a little nodule in duration. Typically you're not going to get too much of the sterile abscess. I don't think I've seen that, but definitely the lumps and bumps and nodules, and they can be really annoying to deal with. I mean, these are ones that are really going to take a lot more effort to break down. You're going to inject them with a lot more Hylenex. You're going to be using potentially even some 5-FU and other things. Because if you don't manage this, I have had, and I've heard, being out there in the training aspect of, I have heard of people needing to go into surgical aspect of it to remove these late onset nodules. They don't go away. And so you want to manage these as soon as possible.
And you said surgery. The majority of these late onset nodules that do need surgical intervention are the ones that are from the permanent fillers, the PMMA.
Yep.
So I have a couple of patients who are just living with them, and they get large hard lumps and they go away. They get lumps and they go away, and they don't know what's triggering it.
Yep.
But you can't take that stuff out. You've got to kind of surgically cut it out.
Yeah.
So that's why hyaluronic acid fillers that you can dissolve are going to be a lot easier to get rid of some of these things rather than some of the permanent fillers. You choose what you want to choose, but just know the risks for yourself and for the patient down the road. Right. They could have an inflammatory reaction, nodules a year down the road. So that's one reason I like to sleep at night. So
yeah, I mean, remember, these fillers can last upwards into the 12-year range. You have to be careful now that we know that these fillers are lasting a lot longer. The talk should not be how long these fillers are lasting. The talk is always, to me, where's the expectation of the patient? Did we fill them up properly? And then with these nodules, you just have to understand that it can be any one of the actual fillers that you've injected in the past that could have caused this. There are certain ones that may cause it more, but ultimately everything. And unfortunately, the filler you injected last is always the culprit.
Could have triggered it.
Even though it could have been just that right timing, everything coincided at that right time, and we blame that one filler as the inciting factor. And it may not have been. It may have been other ones that have been the inciting factor, but something triggered it. And so you just need to understand that how to treat it and how to recognize it. Systemic steroids, hyaluronidase, of course. And then, of course, if that doesn't improve, then you have to kind of get a little bit more aggressive. A little bit of Kenalog, 5-FU, a little Lido.
Make a little cocktail.
Make kind of your own little cocktail. And, try to see if you can break down that nodule a little bit sooner before it becomes something that needs to be surgically managed.
Yeah. I just want to bring up, if you guys want to ask us some questions, we're going to be looking at a monitor here, so we can answer some of your questions if you have any. So feel free to type them in. All right. Biofilm. I've never had one, thank goodness.
I've never had one either, but I probably will say that I have more belief in the biofilm from more of my threads, because I think I've seen that maybe possibly a little bit more. I've seen, not that it's happened to me, but definitely it's happened to a couple people that are around from training, and you're seeing that 2-3 weeks later they end up with an abscess at the distal end of the thread.
Interesting.
Yeah, it's the distal end, not the not the end that you're tying off or that you would think of it. It ends up being towards the distal end or along the whole thread itself. And so biofilms can happen. At the end of the day, any one of these, whether it's threads, whether it's fillers, they are considered a implant. They're a implant that is placed into that area. And so ultimately, could it be just not cleaning well? There's always a possibility. You don't know everything about that. However, knock on wood, I mean, I've been injecting, and when I first got started injecting back in 2004, we're kind of like, okay, alcohol quickly and then inject. And then we go, oh, you know what? I need to inject here too. So I'd inject through, I guess you could say I injected through makeup and all of this stuff back then, trying to be clean, but then not being as cognizant as what we know now with regards to potential biofilms and all these things. So did I see any infections then? No, I never got anything there. And so ultimately, I have yet to really see a true biofilm, but I'm starting to feel as though there can be, now that I've seen it with threads a little bit more, where the infections or the abscesses start about 2-3 weeks later. So it's been kind of interesting.
So they're usually subclinical. Like a biofilm is something that's just like smoldering.
Yes.
It's just something that's like kind of might get swollen, might drop down, might get swollen, might drop down. It's just something there, but never really comes to this big abscess or infection.
And there have been 1 or 2 in the thread.
Really? Yeah, I've never seen that either. Great. Yeah. Great. Wonderful.
So just cleaning as best as you can be, being more cognizant about it. If you are using your cannula, place maybe a gauze with your hypochlorous behind it so that your cannula isn't scraping along the skin and dragging in more.
That's huge. I was
bacteria.
just gonna say that. Be really careful what your needle or cannula touches. I see so many people pretend this is a needle. I see so many. I just did this at a training the other day. I was teaching a surgeon to do injectables and injected a little bit, brought it out and took the dirty gauze, wiped the needle, and I'm like, stop, we're changing the needle. And she's like, what? So it's just you have to be very aware of what that needle or cannula are touching. Don't touch it with something unsterile. Granted, is the face sterile? No, but you don't want to add anything onto that needle that's going to add bacteria to it.
Be clean.
So clean as good as you can, and make sure wherever that cannula is going to touch, if you're laying that cannula down on the face to get the lips injected, that cannula is going to be riding on the face. Make sure this is all clean. Make sure it's all clean. Really important. Otherwise, you're dragging bacteria into the wound.
All right. That was it.
Yeah. Oh, we finished.
Perfect.
Woo. All right. So hopefully that helped. And clarify. I know we went fast, but we kind of went through quickly what we can do in an hour, the little breakdown of what the adverse events can be. And it's not all occlusions. It can be very different things, from nodules to inflammations to reactions. It can be lots of different things. So you're going to have to manage it differently. That means you ask questions. You say, when did this start? What does it feel like? Is it draining? Is it not? Is it hard? Is it tender? Is it not tender? All those medical questions to get down to that differential of what are we dealing with here? And then you'll have an idea of how to treat it.
Exactly. 2 questions I can see. Debbie, where can you get 5FU? I think most you can get it from McKesson.
I think McKesson
or Henry Schein. One of your typical places you should be able to get it from. It shouldn't be too hard to get 5FU.
Good question, Debbie. Yeah. And Kelly, you're asking, when it comes to patients you have not injected, do you treat them for complications as a provider? If patients come in, I have. I've treated both patients with an occlusion, and I've treated patients with dissolving fillers. So yeah, we do. We're there just there to help the patient. So we will help them. We do have them sign a form that states they've been treated somewhere else, and it absolves us of liability as far as dissolving and things like that.
Yeah. So good questions, but just make sure you're aware. Any other questions at all? Otherwise,
we're going to announce our contest.
All right, so we have a new contest. We are putting all of this stuff onto YouTube. So get all your friends to watch us on YouTube, subscribe to our YouTube channel. And so that's what our new contest is about, subscribing to our YouTube channel, and then comment on what your favorite episode was.
That's got to be faulty aspiration, I think.
That's Lori's baby.
Faulty aspiration.
Faulty aspirations.
Yeah.
So comment on it, and we will announce the winner at our next AI Live. So the contest starts from today and goes to the end of the month, November 30th. And the winner will get a free webinar from our library.
Yay.
So lots of digital content that we have out there. So if you are interested in one of that, join, subscribe to our YouTube channel.
And then we have our next AI Live coming up in a month. And we are going to be talking about something super important that a lot of people don't know about.
Rheology.
Rheology. So it's so important to know what the fillers are made of, because you don't know what to choose if you don't know what it is. And like I was saying earlier, it is our responsibility as a provider to know what we are doing to our patients, everything. We need to know the molecular structure. We need to know the medication, how it attaches to the cell. We need to know everything so that we can explain that to the patient and we can better serve them in a more safer fashion. So it's very important to know that. So rheology is key to know when we are injecting products. It's how we choose what we choose to put where.
Yeah, definitely so. Excited for that topic. And if you guys have any other topics that you want us to start covering, let us know. Give us ideas. This is kind of our little fun talk show, just to talk about different things and, you know, challenge you guys to think in a different way and hopefully get your juices flowing with regards to all of this. So if you have comments or questions, you can email us to learn@theaestheticimmersion.com. So learn@theaestheticimmersion.com. Other than that,
or you can DM us on social media too. You can the Aesthetic Immersion is on Instagram. Sure. You can DM us. So our social media gurus will answer you back. So
December 7th, yeah.
So there we go. So anyway, we have lots of stuff coming. We're only going to do a contest, I think, once every other month. We're not going to do it every month for you guys. But hopefully tonight helped make it a little bit more clear as far as what kind of adverse events can happen, when they happen, and then how to treat them accordingly. And assessment is everything. So we have to know what's happening to be able to come down that differential diagnosis and treat it accordingly.
Yeah. All right. Thank you very much.
Thank you, guys. Thank you so much for joining.
Time.